It is October the 26th, 2018, and this is episode 3 of the official podcast of the Royal New Zealand College of Urgent Care. Coming up on this episode, we talk concussion with sports physician Dr. Kevin Bell. We look at ways to remove rings from swollen digits in the nurses' station. We look at how news scores can help identify seriously sick patients. And we look at what the registrars can expect from the upcoming UC-PECS exams. So welcome to episode 3 of the official podcast of the Royal New Zealand College of Urgent Care. My name is Guy Melrose and I'm your host. And today I'm joined by Dr. David Sorrell, our Director of Clinical Training. Yet again, hello David.
Hi, thanks for inviting me.
So this week we are speaking with Kevin Bell, who you will have heard on our Urgent Bites over the last few weeks. And we're talking to him about concussion. His experience is obviously mainly with sports concussion, which is a very common way of getting concussed in New Zealand. So if we hear my talk with Kevin, we will then have a chat with Dave, because your personal interest is head injuries and you've got a lot to say on the topic. So we will hear what you have to say after we've listened to Kevin Bell. Okay, so I'm here with Dr. Kevin Bell, who is a sports physician based in Hamilton. Thank you, Kevin, for agreeing to talk to us. If you'd like to just start off by just telling us a bit about yourself.
Yeah, no problem. I'm a fellow of the Australasian College of Sports and Exercise Physicians. I've been a sports physician since 2014, having done my fellowship in Wellington and Sydney. I'm in sole private practice here in Hamilton. Previously, I've been team doctor for a number of professional rugby and rugby league teams such as Northland, Wellington, the Chiefs and Wests Tigers. I've also dealt with some age grade New Zealand soccer, been to FIFA World Cups, and my area of specific interest, did my Masters of Medical Science and had a original piece of research published in the British Medical Journal on the treatment of Achilles tendinopathy.
Excellent. So thank you for agreeing to talk to us today about concussion. Concussion's becoming much more common presentation, particularly from the sports field. Could you define concussion for us in a medical context, and then maybe tell us how you tell your patients what concussion is in a more lay speak?
Well, concussion by definition is a functional brain injury. So by definition, there's no to imaging and testing that we know as of the current time, there's no structural damage to the brain, but there is some functional disturbance, whether that be in terms of symptoms, vestibular function or cognitive function. Excuse me. And that can present immediately or sometimes can be quite delayed. In terms of how I describe it to patients, I describe it as a brain injury. I think often people call them concussion or even head knocks, which you often hear in the media, which I think underplays the injury. And I very much say to people it is a brain injury and it needs to be respected. Just because you can't see it, people often underplay it and they treat their sore finger or sore arm more seriously than their brain injury. And I explain to people that although the vast majority of them settle down quickly and people make a rapid full recovery, a percentage of them that's not the case, and it can certainly cause people a lot of problems with their day-to-day lives, and as well as sport, work, and other aspects. So I really just try and emphasise that it needs to be respected from the outset and not underplayed.
Cool. So in an urgent care clinic, we see patients usually brought from the field. We won't have seen them on the field. We get a history either from the patient or the coach or the family member. What what is described as happening to the patient when a concussion happens? What are the sort of things that they might describe? The patient appeared on the field looking dazed or knocked out, or how would somebody look when they're concussed in a rugby match, for example?
Yeah, so I mean, I guess the most obvious one, if someone is knocked out, loss of consciousness by definition is a concussion at the very least. So I guess from that point of view, if someone can document that the person was knocked unconscious, or they were told that they were out cold for some period of time, then that's certainly a concussion. I guess the issue with a lot of concussions and general awareness is that people think if they weren't knocked unconscious, they can't have been concussed, yet the vast majority of concussions did not involve a loss of consciousness. And I think that's really important to emphasise to people and the general public, and is I think that's a real awareness issue, and even I think a lot amongst many of the medical fraternity. I think there's thoughts that again, it was just a head knock, you weren't knocked unconscious, but to me there's no such thing as a head knock. It's either a concussion or it's not, and I think if in doubt, we should very much err on the side of conservatism and if in doubt, diagnose it as such rather than be gung-ho, because the potential consequences can be quite severe.
Do they always need to have a blow to the head?
Yeah, good point. So no, they're definitely not. I dealt with a prominent player who has played for the All Blacks in the past, who was out for about 12 months with a concussion, and he got tackled in the chest, and we've seen that on the TV, on the video. So definitely not. So the vast majority are to the head, but it doesn't need to be. A heavy blow to the chest or torso can affect essentially knock the brain around within the skull, I guess, to some degree, and affect a concussion in that way.
So then, what sort of things are we looking out for? What symptoms are we looking for? What sort of a story from concussion point of view? Is it quite broad, or?
Yeah, that's why concussion's so difficult to diagnose sometimes, because people, there's a thousand different reasons you may have a headache. There's a thousand different reasons you might feel nauseated. Visual. Is it an eye problem? Is it a brain problem? People often just vaguely don't feel right. Neck pain. These are just some of the symptoms of concussion, which there's so much crossover with so many other conditions, different forms of trauma, and so you really need to have your antennae on and with a high index of suspicion for the potential of concussion. But there's no textbook presentation of concussion, and that each concussion is different and need to be assessed on their own merits.
Okay. So is that where the SCAT5 form comes in? Is that of use?
Potentially. Well, that's why the SCAT5 has got 22 different symptoms, and people may have 22 of them or just one or two of them, and that's a nice summary of the potential symptoms. Not exhaustive, but a nice summary of them. I think it also need to be aware that some of the symptoms or effects of it may be immediate, and some might be delayed by minutes, hours, or even days. So by which time, potentially, if it's a few days later, people may not attribute it necessarily to the initial trauma, but in most cases they will.
So would you recommend any sports person with an injury mechanism that could have concussed them, we start a SCAT5 and work through and use that as a diagnostic tool? Yep,
I think a SCAT5 is vital. It was brought out from the Berlin Consensus, and it's reproducible. It can be done by any. It's even designed like that to some degree. Non-medical people can do the bulk of it, but it's really important to get a baseline. In a perfect world, we'd have a pre-injury baseline on people, but obviously that's really not feasible outside the professional sort of atmosphere. Although some clubs and teams are very organised and it's very helpful, but they're a very small minority. But no, I think it's vital that a SCAT5 is completed from a symptom point of view, and the cognitive and physical evaluation, and from there it gives us something to work on. After about 10 days or so, the cognitive testing probably has less and less validity, but certainly the symptom evaluation is very important for continuity purposes. So I'll tend to do a full Scat 5 when I assess somebody, whether it be day 1, day 10, day 50. But subsequently, I probably put less importance on the cognitive testing, and more on certainly the balance vestibular side of things and their symptoms.
So if we diagnose concussion on day 1, what would be your advice in terms of disposing of that patient on that day, assuming that they don't need to go to the hospital for an acute brain, a CT scan? How should we tee this patient up in terms of follow-up and ongoing assessment and expectation?
Yeah. So, I mean, obviously, you guys would give the standard, head injury advice, and if things change, need to be assessed, and so on and so forth. But assuming that all goes straightforwardly, certainly in the first couple of days, I suggest to people that they take it quietly. I always explain to people that if they tear a hamstring, they wouldn't go for a run the next day. And I guess to some degree, they haven't torn their brain, but they've injured their brain in some fashion, so they wouldn't go and overwork that. So, and overworking can be both physical and mental. So, as I say, you wouldn't go for a run after tearing a hamstring. So don't go home and read War and Peace, or these days phones and computers, I think, are a real contributing problem. Obviously, young people can't stay off their phones, small screens, bright lights, blue lights, small writing, and that's just working the brain overly hard. So I really emphasise limiting screen time in one form or another, or any aggravating activities. Usually we get parents on side with that. Kids often find that somewhat difficult. And also physical activity, so just taking it fairly quietly for a couple of days. I guess where things have really changed in the last couple of years is that the saying was always rest is best, and people were advised almost to sort of lie on the couch until they felt fine. But we now know that some work out of the University of New York and Buffalo that active treatment of concussion works best. So just like we'd actively treat an ankle sprain or something else, we actively treat concussion. People come right quicker and better. So that's where things have changed quite dramatically. So I tend to say take it quietly for a couple of days, and then we do tend to get people on a graduated return to play from a sporting point of view, but just in general, get people exercising again. A sort of low to moderate form, but preferably jogging or cycling. Sometimes people find jogging, the impact can stir their symptoms up. So I tend to get people cycling first if they can, just at a moderate intensity from about day 2 or 3, even if they've got symptoms. So we used to do nothing with people until they had a symptom score of 0 and they were feeling magic. But now, even if they've got some symptoms, we'd like to get them going because we know it actually helps recovery of their brain. But at an intensity above walking. Walking doesn't get the heart rate up enough to it's been proven to help in the healing process. So how I tend to get people to gauge how intense they go is that when they hop on the bike, to just give themselves an overall score out of 10. So if they're feeling sort of a bit ropey, they might say I'm a 5 out of 10. I say, well, that's fine. Ride your bike at an intensity, the maximal intensity you can ride at without increasing your symptoms unduly. So I'm happy for their general score to go up by 1. So if they feel a touch worse and go to a 6 out of 10, I'm happy with that. But if they go to a 7 or an 8 or more than 2 above where they started, then they're going too intense. They're stressing the brain too much, and they're not helping themselves. So it's just about maintaining that intensity of exercise that doesn't make them feel particularly worse, but beyond a walk. But that's quite new. There's probably only vast majority of practitioners probably not aware of that or potentially comfortable with managing that active recovery from concussion. So So
So in that case, who's monitoring that, and how often are you seeing patients in that
yeah,
time frame?
yeah. So I guess the fact is that we know that about 80 to 90% of concussions resolve inside 10 days. So for most people, whatever they do, they'll be fine by the 10-day mark, and most of them well within 10 days. So I guess it's more the ones who are going to be beyond that. But of course, you can't judge that on day one. There's no way of determining on day one if someone's going to be fine in a day, a week, a month, or a year. So I tend to give them that general basic sort of mantra of trying to keep active without going over the top, staying away from screens and other aggravating activities. And I think it's really important that people seek medical attention on the day, or preferably to be diagnosed, but they need to be followed up. So I think something concrete needs to be arranged. Often we sort of send these people, well, they end up sort of going off into the ether, and we sort of hope that they'll. But the issue is that a lot of people often sort of feel okay, or even if they don't, they sort of just carry on like everything's okay anyway. So I think something concrete needs to be organised, that they be reviewed, preferably in a week or so, because by that stage you'll get an idea if they're in the 80 or 90%, where you can probably make arrangements to get them back into their normal life in terms of sport, activity and work. And at that stage you can also get an idea who might not be falling into that group and might need some further assessment and management.
So those initial people can be managed with their GP or in an urgent care clinic, taking a copy of their scat with them to whoever they see.
Yep.
The ones who aren't improving should then be referred on to somebody like yourself.
That's how I would tend. I probably don't really need to be seeing every concussion on day one. The reality is that by the time I see them, they're probably going to be either side of that day 10 anyway. I think an experienced GP who maybe has a sports medical diploma, or someone in an A&E clinic who deals with these all the time, is certainly very capable of dealing with the 80 or 90% of the straightforward concussions and helping them with that return to play process, which we'll talk about later, I imagine. But beyond the 10-day mark, I think there's real potential that they might be, 3 weeks, 3 months. So I think seeing someone early.
Yeah. And a sports physician is the ideal person in that setting.
I think we're probably the best trained people for dealing with sports-related concussion for sure. Obviously, I see a lot of concussion from non-sporting, people with a car boot hits them and or whatever else it may be. But certainly from a sporting point of view, I think we are probably best placed in that regard for certainly the overall management of it.
And you mentioned earlier that we've got the acute scans, which we're familiar with in terms of referring to ED in the first day or so. But there isn't really a huge need for imaging beyond that. So we shouldn't be, if we are referring people onto you, we shouldn't put the expectation of a scan in the patient's mind.
No,
necessarily.
No, very much not. We know, as I said before, the concussion by definition, all the CT, MRI, etc., are by definition normal. And so very rarely do I request any imaging. The only time I tend to request a scan would be in somebody whose presentation is increasingly chronic. They're not showing signs of improvement. Or there might be some neurological signs, which is relatively uncommon. But from my experience, every scan I've ever requested, I think they've always been normal. So it's often to keep people on side and that you are sort of taking note of the fact that they're having a prolonged recovery.
And in terms of patient expectation, seeing them first up, we probably want to try and give them some kind of expectation realistically. And a lot of those expectations evolve around when can I return to play sport. I understand that's probably quite an elastic answer, but what's the framework that we should be thinking of in terms of returning to sport? When does it start, and what pathway do they follow?
Yeah, so I tend to say to people that make it quite clear that there's no way of predicting, because invariably they say, little Johnny's got rep game in 3 weeks, and I said there's no way of predicting when he'll be right. There's just no test or scan or anything else that helps us in that regard. So I try and set out a realistic time frame, in as much as it's open-ended. Particularly in terms of rugby union players, there's a lot of talk around the 3-week stand down, and people sort of get somewhat fixated on that they're counting down the days. And look, the reality is that some people probably would be potentially fine to play inside that, but there are also a lot of people who 3 weeks is not enough, and that's a minimum stand down. I make that very clear as well. It's a minimum stand down, and for kids under 19 now, it's actually a 23-day stand down. So it's actually essentially a 4-week stand down for people under 19, because we treat children, adolescents, a lot more conservatively, because they tend to recover slower, and there is a condition called second impact syndrome, which is very rare but devastating. When people have a concussion on top of a concussion, they can literally drop dead. There have been a number of documented cases of that. So tend to sort of get that out there quite early, but also tend to give them a bit of light at the end of the tunnel by trying to actively treat them and getting them doing some exercise, because give them some written advice in regards to that. So as I said before, we try to get people jogging by the 2 or 3 day mark, and I give them a bit of a summary often, as I said, in writing, and go through it about the different phases that we're going to go through, even if they're up and running well before the 3-week mark in terms of rugby, that at least they're in a position to proceed. The other issue is that obviously they watch the Saturday night on the TV, and such got knocked out, and he was playing a week later, and that in the community game of any sport, that's just certainly wouldn't happen at a local level. You could argue whether it should happen at professional level, but for the best of our medical knowledge, if people have gone through all the steps without symptoms, to the best of our knowledge, that's something we consider safe, but that may not always be the case.
And are there resources we can refer to through the rugby union, or in terms of a return to play kind of pathway?
Yeah, so the blue card was brought in up north in Northland after the Sabin boy had a bad injury, and they started that quite some time ago. And so if you're given a blue card by the referee, although parents, coaches, anyone can actually give a blue card, I don't think that's well known, but then within the union, they at least have it on record that players shouldn't be back playing within a minimum of 3 weeks, and until they're cleared by a doctor. So you need to be cleared by a doctor once you're back up and running again as well. But the vast majority of concussions I see have not been given a blue card. It hasn't been recognised at the time. Maybe symptoms were delayed, for example. So to some degree, it's a bit more honesty based, because there's no actual overall sporting body oversight, and that's the same for hockey, soccer, rugby league, where there's no specific mandates. So there are many cases of people who inappropriately go back and play, although we certainly discourage that, but it's very difficult to stop people if they're determined to. But
so what's the best thing to refer to if we're going to clear them back? So we haven't referred them on to a sports physician, they've come back at a week and their symptoms are better, and they maybe play netball or hockey, or is there a framework that we can
very
follow?
much so. So there's a standardised graduated return to play protocol, which was in the Berlin consensus statement, but stage 1 is the low intensity cycling, jogging sort of thing, and once people can do that completely symptom free during and after for 24 hours, the next step is I tend to get them doing stage 2 is a bit more of a higher intensity, so it might be some sprints, some shuttles, things like that. The next stage is more rugby specific, sports specific. So it might be with their hockey stick, hitting some balls, kicking some balls, doing some running around and passing some balls and things like that. So it's a bit more sport specific with a ball or such like. And again, if they have no problems during or after, then the next step is a non-contact, certainly in contact sport context, as a non-contact training. So I say you can go and do some line-outs or some, full team training, just nothing where you potentially will run into contact with anybody else. And they can also do weights on that day, because a lot of people are chomping at the bit to get back to the gym. So at that stage, they can get back to the gym. And if that all goes fine, then ideally we like to then clear them to commence full contact training. So they really should see a medical professional, a doctor, to be cleared to return to full contact training once they've managed a non-contact training and gym. And if they're completely asymptomatic, maybe their cognitive function looks good and their balance looks back like it's back to baseline, then we'll clear them for full contact training. And I emphasise to people it really needs to be a full contact training. I had one case when I was in Wellington where a player didn't really have a decent contact session, and they didn't sort of really respect it, and sort of gently tapped a few tackle bags, and he ended up being out for about 6 months, I think, when he played when he probably shouldn't have. But there was a lack of disclosure, which is another huge issue with concussion, is that it's not like a broken bone. You can say on the x-ray it hasn't healed. If someone looks you in the eye and says, I feel 100%, and then ticks zeros down their symptom score, I guess you have to take them on their word. But I think there's increasing awareness with patients and players and parents that it's just not worth the risks of trying to pull the wool over our eyes and so on and so forth. But once they've ticked all those boxes and they've got through a full contact session, which I say to people, make sure you get tackled and make some tackles in the rugby context, then we deem them fit to play.
Is there a maximum number of concussions in a period of time? So if they've had a concussion, gone through the process, cleared, and then 4 weeks later they get another one, are there rules around recurring ones?
Yeah, good question. And that's the $1 million question to some degree, and then very commonly asked. And the answer is no. I mean, there's no magic number. 3 concussions, 4 concussions, five in a year, 5 in a lifetime. So no, there's no one answer to that. I guess to some degree that's where a little bit of the art rather than the science comes in. There's certainly there's lots of factors. How many have you had in a year? To me, if someone's had probably more than 2, certainly in a child or at a community level, I would start to be thinking that really, do you need a 3rd and a 4th one in a year? I don't know if that's in your best interests, but there's no science really behind that. Are people having symptoms for longer? Did their first concussion last 3 days, the second one 3 weeks, and the third one 3 months? So that's a trend we wouldn't like. Are the concussions occurring with less and less force? Often by the end of it, sometimes the force or the blow can be very low key. So those are factors that would maybe think that things aren't going in the right direction. Other confounding, mental illness and other things like that may also affect your thinking. But there's no one specific number or length. I mean, there's been well-known cases of players have concussion lasting a year and return to play and then go fine after that. So there's no rhyme or reason to it sometimes.
And what about the role of head protection in concussion? Are they recommended? Do they help, or are they a hindrance?
Yeah, so obviously a few years back, headgear was very popular. And also in boxing, it's even not compulsory in amateur boxing now, because there's no evidence that headgear protects from concussion. It is good for cuts and bruises and so on and so forth, but there's even some school of thought that it potentially could put people at higher risk because they've got some headgear and they fly into things a lot harder than they would if they only had their head, such as American football, where people the players use their helmets almost as a weapon, use their head as a weapon almost. So it's potentially, it puts people at increased risk, but certainly doesn't help in that regard. Mouth guards, the evidence tends to go for and against in terms of concussion prevention. So there's some studies showing they may have some small effect on prevention, and others saying that there's no effect there. But certainly in terms of oral and tooth, so you don't lose a tooth. Certainly we encourage that, and it's mandatory in some sports. So, but the thing that has been shown relatively recently to have an effect in terms of reduction of concussion is strengthening of the neck. So that's something I brought in to one of the rugby teams I was involved with, and some of the guys grew quite big necks. But yeah, so neck strengthening has been proven to reduce the incidence of concussion.
And just finally, is there any role for any medication in concussion management, analgesia or any other? Yeah,
look, I think the headache's no fun for anybody, and paracetamol would be my first line, and probably if someone needs an an ibuprofen, Voltaren on top of that in the acute phase, that's probably prefer not. But anything more than that, then you've got to wonder, is this headache, suggesting that if someone needs more than that, then I guess you'd have to be somewhat wary there might potentially be more going on in that very acute phase. Subsequent to that, in the more subacute or chronic phase, then we may consider things like amitriptyline or nortriptyline can be used for managing. That's sort of the next level beyond specific painkillers or anti-inflammatories for certainly headache sort of based symptoms. And also a lot of people with concussion have what we call sleep latency, where they have trouble getting off to sleep. And sometimes amitriptyline or medications like that can have their place there just to give a good night's sleep. And then that often helps a lot of their other symptoms of tiredness and just feeling a bit under the weather, because if you don't sleep well, you generally feel a bit off anyway. So I don't tend to use any more medications than that. If people are needing more than that, then maybe they need to see a neurologist or someone like that, or there may be some alternative diagnosis. But I find simple analgesics and amitriptyline tend to work for most people. The other thing that's been proven to have a real effect on people's recovery is treating their cervical spine. So if people have neck pain, some degree of their headache may be cervicogenic in nature. So it's been proven if people have a concussion, and particularly if they have neck symptoms, in addition to that treating that early and treating that aggressively with physiotherapy or such like makes a real difference to their outcome. And likewise vestibular dysfunction. So excuse me, it's often, I think, overlooked that the inner ear and balance and so on and so forth can really be knocked around by a concussion as well. And we know that treating that early makes a definite difference to people's outcome.
And who would do vestibular treatment?
So there's obviously the neck is probably a bit more bread and butter for physiotherapists. There are a relatively small number of physiotherapists I know in this area. There's a couple who've done the courses and tend to prescribe patients a set of exercises they do each day. So it's a matter of finding somebody who's trained specifically in vestibular-based rehab. And as I said, most areas will have some physiotherapists in that, or potentially you may be able to access that through the ACC concussion service, although that can be somewhat difficult at times.
Excellent. Well, thank you very much, Kevin, for talking. Do you have anything else to say at this point? I think we've covered everything from an urgent care point of view. I imagine there's a lot of things that over the next 10, 20 years is going to come out in the science maybe, but I think if we follow that framework of the SCAT5 and those sorts of points that we've covered there, we shouldn't go wrong at this stage.
Yeah, I'd hope not. But yeah, I just think we just need to be educating our patients and parents that it is a serious condition. It is a brain injury, and And look, if in doubt, someone like myself I'd probably rather see them early and find out that they've come right, than because the ones we see that 6 or 9 months down the track it's really can ruin some people's lives. So.
Excellent. Well, we'll include the links to SCAT5 and the other things we've discussed and your details in the show notes, Kevin. So thank you very much for talking to us today.
My pleasure.
That was Dr. Kevin Bell telling us all about concussion. And Dave, what are your thoughts and comments on what he had to say and concussion in urgent care in general?
Great, thanks. I wrote down a few points after listening to it, and I'll go through the ones that I think are important. Imaging of the brain is only necessary when you think there's a structural brain injury. So all imaging is always normal in pure concussion. What concussion is very controversial, but I like to describe it to the patients as it's a metabolic disturbance of the brain. So it's like your brain can't use energy properly anymore until it heals. And so it's kind of like driving a manual car when the gearbox is broken. And if you can imagine trying to drive from Hamilton to Auckland in first gear, it's very difficult. Your brain gets fatigued, it gets very sensitive, and so that's what it's like for the patient. Another point that I think was raised is that it's very difficult to say someone isn't concussed. And so it takes always more than one assessment. And the concept of delayed concussion, yes, it can be seconds, minutes, days, or weeks later. And by the time I see these patients, it's usually pretty obvious. But even I can't say someone isn't concussed in just one visit. A very important point is when someone has prolonged concussion symptoms, there is only one diagnostic code that should be used, and that's concussion. So mild head injury or head injury doesn't convey any follow-up with ACC. I would personally avoid post-concussion syndrome. I usually call everything concussion or S60, because then if I want a concussion service or someone else like a sports physician to follow it up, the ACC will fund it. Otherwise they won't. My other big point, I guess, is history. So often you get someone who has a concussion and they say they were fine. Collateral history, if you can get it, is very important. Someone who is unconscious for 30 seconds always has concussion. It may be mild, it may not be mild, but that automatically conveys a diagnosis of concussion. And yes, traumatic brain injury or brain injury is a better term to explain it to the patients, and I think he did that very well. The sideline concussion assessment tools are very good, but also very time consuming. And I think it's great if someone else can help do those. So a nurse or a physio doing most of the paperwork, it makes it a lot easier. And in my clinic, I have to do all the forms myself. And so I don't actually do these sideline concussion assessment tools very often, apart from the symptom scores, because that's what I'm usually involved in. There was some mention about vestibular rehabilitation, and that is a very important service, and usually that comes through the concussion service because they can get better funding. They can also get people seen with tinnitus problems as well, and I know that there's Auckland Tinnitus Service can see people for ongoing tinnitus. When someone is an athlete with a sports concussion, I think the sports physicians are very important when you have someone who has sport as the most important thing in your life. And in elite athletes, or my question is sports the most important thing in your life at the moment? And if that's the case, I always refer them to a sports physician because they can give them the most accurate clearance for return to play. And it's not that easy. And you can see that with the different code recommendations where there's no consistency for time off. And so, when the CDC reviewed the literature on concussion in children, they found the worst outcomes are usually between the ages of 10 and 17. And so I err on the side of saying you're 28 days off as long as you're completely well, and longer if you're not. So that's my 5 cents worth in concussion. I do see a lot of concussion, and I have a concussion clinic for 1 hour on a Monday and 2 hours on a Tuesday, and most of my patients aren't sports people. So I supervise their return to sports, return to school, and return to work. And I always involve a concussion service. The one I use is called Active Plus. And I do referrals after 10 days usually if the patients are still very symptomatic.
Yeah, I think one thing we're looking to do in a future podcast is catching up with some of these vestibular rehab people just to learn a bit more about what they do, because I'm aware we need to refer them on to these people, but I'm not 100% sure what they do. So we'll certainly try and get those involved. But I think concussion services around the country are different. So you think everybody needs to become familiar with what their services are?
If I was you, I would find what are the services in your area, and if possible, find out and get contacts for those services. And then when you're doing a referral, my preference is refer directly to the concussion service with the forms, so an ACC 883 for adults and an ACC 7412 for those under the age of 15, and send them directly to the service, because then they will make ACC get moving on it, because ACC can be very slow at times. If you're relying on ACC to find a concussion service, things can get bogged down.
Yeah, and it's important what you said about coding this as an S60 so that there's no confusion or no wriggle room for any of these to fall through the cracks.
Yes, and the other thing, I guess, is the term post-concussion syndrome. Patients don't tend to get better from syndromes, so it's better to call it persisting concussion symptoms as a diagnosis and code it as S60 unless more than a year has elapsed. If it's been more than a year and it hasn't been registered with ACC, it's going to be a nightmare, believe me.
Yeah, and I think that's a lot of reasons some people do present now with head injuries is to get an ACC diagnosis, because they're aware that concussion has longer term or potentially longer term manifestations, with all the evidence coming out of the States with the American footballers and the like. So
yeah, and the other thing is, how mild is mild traumatic brain injury? Well, for some people it's completely life-changing and far from mild. The term mild is basically determined within the first 24 hours with things like your GCS, loss of consciousness and amnesia. And after that, nothing actually changes it from mild to moderate to severe.
I think it's James Cracknell is the British Olympic rower who wrote a book about concussion because he got knocked off a bike cycling for charity. He got the wing mirror of a truck hit him, and he had quite bad post-concussion syndrome for a number of years, and his wife and he both wrote a book together about her experiences of living with him after the head injury, and that's an interesting story on one extreme end of the scale, because his was definitely not a mild traumatic brain injury, but it was it was certainly classified as concussion. You also mentioned in your notes about medications for concussion. So if they've still got symptoms and they're needing medications, then they're still concussed. So they're still...
So I use medications for concussion. If someone is medicated, they cannot return to sport. They can return to exercise, but they can't do contact sports. So the medications are actually very mild and only useful for sleep and headache. So use a lot of amitriptyline and nortriptyline at very low doses, 10 to 30 milligrams. I use magnesium. So magnesium has been known to be a migraine preventer for a number of years, recommended by the American Headache Society. And 400 milligrams of magnesium a day can be used to manage headache quite effectively. It's often combined with vitamin B2. So they have a medication called Migradol, which is 3 tablets once a day continuously while having concussed headache. Sleep is also of concern, and so melatonin is used. And I use an inexpensive version because there's no real consistency in New Zealand. It's a 2 milligram slow release, and you can have between 2 milligrams and 10 milligrams at night to help with sleep. One of the issues is funding. So magnesium and melatonin are not funded. There is an extremely complicated form that can be filled out through ACC, but I'm still waiting to get almost any of my patients accepted for ACC medications. If those medications don't work, then there's a long line of second alternatives, which I'm not a fan of, like Epilim and gabapentin, Topamax, and usually I would get a neurologist to discuss those options.
Do you have a stance on simple analgesics after head injury?
So
paracetamol's obviously
the service that I use recommends Panadol and ibuprofen. The things that are no-nos are codeine, tramadol, and sleeping tablets. Those three things should pretty much never be used in concussion because they're addictive and not helpful and often cause rebound headache. Even Panadol and Nurofen can cause rebound headache. So you have to be careful, but often they're the best way to go. Certainly the first 10 days, Panadol, Nurofen. After that, consider a preventer medicine. It's a problem of brain sensitivity rather than actual injury after that point. There's no ongoing damage to the brain, but it's very sensitive, and so preventer medicines work much better than treatment medicines.
And do you have any kind of standard off-work kind of guidelines from a point of view of, because my understanding is that if it's a brain injury, it doesn't matter whether you're doing keyboard work or driving a car or digging roads, it affects every job potentially.
It's extremely individualized. So you make a plan based on the patient's symptoms. And so if the person is in front of a TV screen or a monitor all day long, that is going to be an issue. If they are climbing up ladders and working on scaffolding, that's going to be an issue. So you have to think and review. So some of my patients are starting at 1 hour, 3 days a week for 2 to 4 weeks. Some patients rapidly get back into their full-time work. And it's very much go with the flow, and you can't use standard regimens. It depends how symptomatic they are, of course. The big thing, I guess, is exercise, that there's no benefit of exercise rest after 2 days. After that period of time, you can start gentle exercise, and we all know that the athletes go stir crazy unless you allow them to exercise. But it's also always the most important thing is they must not get a secondary injury.
And with regards ACC now, we're being encouraged not to give fully unfit for work certificates. Do you ever do a fully unfit from concussion?
So the first 3 days is a good idea to be fully unfit for work. What I'm telling my patients when I see them is, look, I want you to get back into work, even if it's a tiny amount, and even if you're actually useless at work. And we've seen that with students and with workers of any employment, it's very useful from a socialization point of view to get them back in. So students have 3 days off school and then start back at half days with an out. Say you can go to the library, sick room or home if you're feeling unwell, and all the teachers must know. Employment is so individualized, but if people are off work for a prolonged period of time, weeks and months, it's very hard to get them back to work. The biggest deal is with employers who say, I want you back when you're all better. Most of the people I see in concussion do not get all better very fast, and I see people up to a year after the injury. So the last thing I want to do is to have them completely off work until they're all better, because it takes so much longer for them to be all better. With your rapid healers, that's okay. So you have to often do a trial and a graduated return to work.
And then just finally, your thoughts on urgent care's role in the monitoring of these, because we obviously see them on day one, often when they've had the acute injury. Somebody like yourself who's got an interest and a sort of an advanced knowledge in it, runs a concussion service on your Mondays and Tuesdays. What are your thoughts on how we should manage it in urgent care going forward?
So what I see it is what is your interest? From my point of view, I don't see post-concussion syndrome. So if there's a huge psychological component or it's been more than a year, I say I cannot be your carer. If there is a lot of psychiatric conditions, I'm not as experienced in that. What each doctor has to decide is, are they comfortable managing concussion and for how long? Maybe they want to manage it for the first 10 days, maybe they want to manage it for the first 21 days or 28 days for return to sport. Maybe they'd rather say, well, I would really prefer you to go to a sports doctor or your GP. If you are a GP and an urgent care doctor, then you're probably going to be very comfortable. But you need to fill yourself with resources and find information so that you can give information to your patients, as well as verbally and written forms with what the plan will be. But it's what interests you and what you're comfortable with.
But it should probably be a booked appointment service, not a through the floor of an urgent care. It's potentially too time consuming to do it properly, to just have an ad hoc shop floor review.
Each first concussion review with me is 45 minutes usually, and that's challenging for even a booking system. So I like to have mixed bookings between reviews and simple. But the ideal for follow-up is that it's a booked system. It also is easier for the patients to manage, and it needs to be a consistent doctor, ideally.
So when we've seen somebody on day one, they need to be followed up either through a referral to a specialist, GP, or if you do bring them back to your clinic, it's better to have a booked service with somebody dedicated to spend the time to see them, and not just say come back in a week through the drop-in.
That's best practice. However, if you're a permanent doctor in an urgent care clinic and you know when you're working, you may be able to fit that in. But it's not great for patients to be seeing lots of different doctors for the same concussion. I think a lot of people would be comfortable with reviewing them for a second time before they go back to their GP, or a return to school type thing. But you have to go with what you're comfortable, I think. You have to know a lot about concussion to do it very, very well, but it doesn't mean you can't learn as you go.
Great. Any further comments on this? It's fairly comprehensive. It's certainly, concussion is something that's going to be a hot topic for the years to come, I think, as we learn more about.
Yes, I think one point I would make is it's virtually impossible to clear a person with one visit. And so there is always a series of visits to say that this person is better. And so be very careful with someone turns up at day 20 saying, I need a clearance to go back to rugby. You need a lot more information than that.
Great. So we will move on now to the nurses station. And today we're talking about a topic that you put on Facebook, Dave. You put a post up on removing rings from fingers that have been injured. So we'll pop to the nurses station and then we'll have a quick chat about that in a second. So welcome to the nurses station. Today I'm joined again by nurse practitioner Amor Kisling, who's an urgent care nurse practitioner. Thank you for joining us again, Amor.
You're welcome.
So today we're going to talk about removing rings from fingers. We see a lot of hand and finger injuries in urgent care, and if you've got a tight metal ring around your finger that's going to constrict when the swelling occurs, it's not long before the digit turns a funny colour. And so it is a priority to get the ring off, and there are various different ways in which you can remove rings. So if we start at the beginning, what's the easiest way to remove the ring?
So first of all, it's quite important to identify it early, that the ring needs to be removed. Any injury that can cause swelling in fingers or toes, if someone wears rings on their toes. When we do it, you need to use a lot of lubrication. Any lubrication that you use in your clinic will be fine, or soap or anything that you can use. The other option is we can use a string technique, and there's also a Coban technique that we can use to reduce the swelling. Or in the end, if that doesn't work, we need to cut it off, and we can talk a little bit about more different metals. If that's
cool. So the simplest thing is obviously just to pull the ring off if you can, and if you get there early enough, it may just slide off regardless. So it's often a case of saying, hey, I think this is going to result in swelling. Let's take the ring off now and put it to one side. And you sometimes get some pushback from people, particularly elderly people, who might say that this ring has never been off their finger in a millennium. But that's, ultimately you've got to say it's your finger that will suffer at the end of the day. But if you get there early enough, just sliding the ring off at the time. And you're right, it sometimes does need some lubrication. So something along the lines of your KY jelly, etc., is all good. If the finger's been injured, then it may be quite painful. So I guess a ring block is sometimes necessary if you are going to be yanking on the finger. But then you might be considering one of the later techniques. Now you mentioned the string technique. So describe to me what that involves. How do I use a bit of string to remove a ring?
So you put the first part with a little tweezer or forceps underneath the ring on the bowler side, and then you wrap it proximal to distal, wrap it nicely tight until probably halfway across, and then you can start pulling on the little piece of string that you've put underneath the ring, and then you pull the ring, and it usually just slides off over the area that you've put the little string around and compress the finger.
So the distal wrap is squeezing the finger to provide less swelling to get the ring over, and then you're using the bit you push through to kind of lever the ring along. Is that right? That's
correct.
You're sort of shimmying it along the finger until it pops off, and that can be done with I've seen it done with string, ribbon, dental floss, any of those sorts of things.
It actually works quite well with the little elastic that you get on the oxygen masks. That's actually a nice
so the
one to
bit
use.
that holds the mask onto the face.
Yeah, you just take the elastic out from the sides. That works quite well.
Cool. And then the reason this topic came up is that Dave, our Director of Clinical Training, put a post on the website about a technique he'd just become aware of, and I'd never heard of it, but it certainly sounds quite sensible, and that is using Coban, which is that elasticated self-adhesive tape that we use for other injuries, and vets use it a lot, often called vet tape. And I guess the principle of that, the link is through the college website, is for using the elasticated wrap to squeeze the swelling out of the finger, and coupled with some elevation, you can try and get the swelling down that way. So it provides a nice even wrap. So if you've got the thin stuff, I guess you'd start at the tip and wrap down, would probably make sense. Or you've got the thicker stuff, that would probably just be one wrap around the finger. But that's a nice technique. So anyone listening, if you pop to the college website, go to the posts page, and then look under ring removal. But essentially, you're trying to get the swelling down and then slide the ring off the finger as easily as you can. But that's to maintain an intact ring. What if push comes to shove and you can't get it off? Then you've mentioned cutting the ring off. So how do you cut a ring off the finger?
So you use a ring cutter, and probably only just the soft metals like gold. Any metal like tungsten or ceramic, they will just shatter and they can cause secondary injuries. Other things like titanium, and I think platinum is also really hard to use a ring cutter and can take quite a while. So your options there, if you can't get it off with a ring cutter, you'll either have to see if you can get the person to a jeweler or ring the fire brigade, because they're quite happy to come and cut it off.
Yeah, it is something that whoever pays the bills at your clinic will not be happy if you sit with your ring cutter. Most of the ones I've seen are manual, but there are some that have an electric component. But it's got the shield that goes under the ring, and then you're grinding this disc. You know pretty quickly if you're cutting metal, because you should get little groove appearing. If you continue to use it on a very hardened metal that's never going to cut, you're just going to end up with a blunted disc very quickly, and someone's going to have to order a brand new one. So be aware of the metal that you're cutting. The good thing, as you say, is that there is the option of the fire brigade, and it is technically an emergency that this finger will fall off if it's left too much longer. So they're usually happy to come around and use some of their pneumatic gear to get it off, but sometimes a jeweler is another option, and those ring cutting. Obviously, you mentioned the other metals that can can shatter, you've got to be careful with those, because if you cut a gold ring, it just splits in two, nice and safely. But if you're cutting something or trying to remove one that shatters, then it's a danger to eyes. So eye protection and the like has to be worn. And yeah, it's one of those things that if a patient's not keen to have it taken off, they'll be back when the finger starts to get very, very painful and blue and starts to drop off. So you have to sort of say, look, it has to come off. I know sentimental value is there, but yeah, I think the main thing is if you recognise early that this could proceed to become a swollen finger, just get the ring off sooner before it becomes a problem. That's probably my best tip. We'll put a link to some videos that show how to use the wrap technique, but I think you described that pretty well. Anything else to mention?
Just make sure that you give the ring back to the patient.
Yes, that's a good point. Yep, as always, just if you're taking anything off rings, watches, etc., make sure it goes back to the original owner. And when you do cut a bit of gold out, you are losing a little bit of the band. So but a jeweler will be able to resize the ring for the person, and it's the sort of thing that a lot of household insurances will cover. But I don't believe ACC would cover it. They don't cover things like broken glasses or broken dentures. They may cover that, but certainly I've seen people who have fallen and broken glasses, and ACC don't cover that, so they wouldn't cover the repair of the ring, but it shouldn't be too expensive to get it redone. But yeah, we'll make sure they get the ring back. So yeah, check out the links, and just bear those in mind next time you see a hand or finger injury. So thank you again, Amor, for joining us. We will no doubt chat again in the future.
Yeah, no, it's always a pleasure. We'll talk soon.
Cool. Thank you. And we will see you, everyone, again in a month on the Nurses Station. So that was the Nurses Station, where we've looked at the various different ways of getting rings off fingers. And my sort of main point is identify it early and get it off before it becomes a problem, before the person comes in with the ischemic finger. But your post, Dave, was referencing using Coban to reduce swelling, which was something that I'd never come across before, but on thinking about it, it makes total logical sense, and I can't believe I've not done that before.
Yes, it's very interesting. One of the doctors I worked with showed me a simple technique, and basically you wrap the finger just as you would to manage edema with it elevated, and give it a few minutes for the swelling to go down, and then you can try the other techniques to remove the ring. Obviously you can't leave the Coband on to try as you try to remove it, because Coband is not quite that slippery, and it's in a trial of one patient, it seemed to work very effectively. It's not always going to be effective, and the thing about ring removal is you've always got to have a plan B or a plan C. And I've always used the dental floss or thread method of spinning the ring around, but I've found it more and more difficult, and I don't know if that's my own age coming to play. I know that you've always got to have the backup plan of, if in doubt, get it cut off. And the ring cutters that we have in the clinics are very inadequate. So they do work with very soft metals. And you've also got to be aware of the metals you can't cut. So very strong steels and tungsten rings. So your route has often got to be fire service or a jeweler. So I know that there's a jeweler near us that says, hey, if you send the patient in, we can cut the ring off. And even some dentists are happy. I used to work with a dentist who said, I've got a diamond bit drill, I can chop that off in 5 minutes for you. So if you do work in a clinic with a dentist, ask them if they're a bit happy to do that. It's probably the most interesting use of a dentist's time. Or if you're close to a jeweler, could they do that for you? But early recognition, very important. So one of the things I say is I show my registrars an x-ray of a fracture with a ring on the finger and say, what's wrong with this picture other than the fracture? And the trick is to say, whoop, there's a ring on there. We need to get that off. And of course, if you've taken an image and you've got the picture with the ring on it, and a week later the finger is looking necrotic, there is really no defence there.
No. And the good thing about using a jeweler is that they can cut it off, but they can also then offer the repair afterwards, which the fire service obviously wouldn't do. But so that's removing rings, which is a common enough thing for us to have to do.
One other point there, early recognition, is often you've got a narrow band of time where the ring will just come off really easily. And so often with my patients with wrist injuries and hand injuries and finger injuries, I say, look, can you get off that off right now? And I'll give you a little plastic bag to put on it, and you must not put it back on for a week. And often that will save you seeing the patient the next day with the inability to get the ring off.
Yeah, and also if patients learn to recognise that, then out in the community they'll take it off before they even get to us, hopefully, if we get that message out that it's easier to take it off earlier rather than later. So if we move next to some email correspondence on some of the topics we've discussed this month in the Urgent Bites. The first one was we go back to NSAIDs. So we discussed NSAIDs in episode 2 relating to fracture healing, and really found that there wasn't any evidence that it delayed healing. But then I spoke with Kevin Bell about soft tissue injuries, and there's certainly a school of thought that soft tissue injuries don't favour in the acute phase from anti-inflammatories. And we had certainly one comment on the Facebook page that was in support of avoiding them for acute soft tissue injuries. So I wonder what your policy on using NSAIDs are, because we're between a pillar and a post, really, because we need to give people pain relief, but then what are the options? You can give codeine and tramadol, but then they don't come without their risks, and some people need more than just Panadol. So
it is a great challenge, and I think pain relief is always a challenge. There is no such thing as a perfectly safe pain reliever, and so I think that non-steroidals in acute soft tissue injuries are for pain relief, not soft tissue management, and sometimes they are the best option. So if you've got a 12-year-old or a 10-year-old with a collarbone fracture and they're in a great deal of pain in the first week, they need pain relief. So similarly, if you've got an 8-year-old with a nasty ankle sprain and they're very sore, what are you going to give them for pain relief? You're not going to give them codeine. You're not going to give them tramadol. Panadol might just not be enough. So you have to be able to give them an option for pain relief. So I don't use anti-inflammatories for anti-inflammatory effect in acute soft tissue injuries. I use it for pain relief. And so certainly if you talk to the hand therapist, they'll say, to get the hand moving, it needs to be less sore. So they're quite in favour of a short course of anti-inflammatories. And it's a bit of a balance. So maybe you instruct your patient to say, look, if it's really sore, use this. If you don't need to use it, stick to Panadol. I think there are issues with codeine and tramadol. Sometimes they're used, sometimes they're not used.
Because you put a link on Facebook to the Herald article that Lizzie Marvelly wrote about tramadol addictions, and it certainly has, and you say it's made it to the mainstream. It's certainly not without its addictive properties and other side effects. So, as I say, if somebody's in pain, you do feel like you have to do something about that.
Yes, so you've got to look at each patient and ask them specific questions. So obviously codeine is a real no-no in the breastfeeding woman now, and in the elderly is associated with falls. Tramadol, well, yes, I often ask, what have you used for pain relief in the past? And I also have to check how much tramadol they've had recently to see that they're not actually drug seeking. And so for some people, tramadol is a good drug. For some people, it's not. For some people, codeine is okay. For some, it's not. For some people, Panadol's okay. Some people, anti-inflammatories are okay. It's interesting when you consider someone who has severe liver failure. The only really safe drug is Panadol, but at a different dose. Because you don't want to cause bleeding with an anti-inflammatory. And someone who has cirrhosis of the liver and severe liver failure, anti-inflammatories can be very dangerous, and similarly codeine and tramadol. So Panadol at perhaps 1 gram per day, after discussion with a gastroenterologist, turns out to be the safest option.
And there's obviously other non-pharmacological things. Ice seems to be quite effective for bad sprains. It seems to numb people. People use TENS machines and
remember with
and
ice, that ice is used temporarily. So I've had a patient with a pretty much near full thickness. It turned out to be probably a deep dermal burn, nearly requiring a skin graft because they put ice around their ankle and then taped it on for an overnight's time. So 10 minutes to 20 minutes maximum each time.
Yeah, so even ice is not without its problems. And then things like splinting for pain relief in certain circumstances.
Splint and elevation is very important.
And Kevin also did a talk on tendinopathy, which was his one of his personal interests, and it was interesting hearing him say that once you've developed a more chronic tendinopathy, there's no inflammatory cells in there, so he wouldn't recommend anti-inflammatories in that use. So certainly anti-inflammatories seem to be, depending on where you use them, there's pros and cons, and we shouldn't maybe use them without some careful thought as to why and for how long we're using them in whatever we use them for. The other bit of feedback we had was just a comment on the going back to episode 1, the using or obtaining of urine samples in kids. We had somebody who commented that they've recently done a PEDS run in hospital and feel very comfortable with doing catheters. So I guess if you take that skill into your community practice and maintain the skill, it could be something that you could be good at doing and be a useful thing to use in an urgent care clinic. But if you haven't got that skill, learning it within an urgent care clinic is not really the place to do it. So
yes, I think that you need to have someone skilled teaching you how to do this, and doing a pediatric catheter is probably not something you do without someone telling you how to do it properly. And most of the PEDS nurses I worked with were far superior to me, even by a long shot.
Yeah, but I think if you've done that in a hospital setting, maintain that skill is probably the way forward.
Yes,
because it would be great to have someone in your clinic who could do that, because it would certainly save a bit of referral time and faffing around. So the next thing we'll move to is some brief news. There hasn't been a huge amount of relevant news from overseas, but there was a couple of cases that I wanted to talk about. And the first was that stuff.co.nz, doctor missed big red flags about pneumonia, and this was a coroner's report. So what were your thoughts reading this story?
So I have had the ability to look at this before this case, and I did have some thoughts. So there's an organisation called Safety in Practice that reviews, in general practice and in urgent care, management and practices within a practice. And one of the things we were looking at was identifying the seriously unwell patient. And so this came about with hospitals having emergency med teams and the news score, or the National Early Warning Score. And we were looking with the Safety and Practice group of identifying the seriously unwell patient within, in our case, an urgent care clinic. And so we looked at, could we modify the score? And when you consider it, I do remember discussing the pneumonia severity score, the CURB 65, versus the news score. And a lot of the time I feel the news score is much better at actually assessing the seriously unwell patient. So if we were to say, let's not just talk about pneumonia, let's talk about meningococcal, let's talk about severe influenza, the things that are in common, the things that are in common in all those situations is the patient appears severely unwell because they're medically shocked. And so you have a rapid heartbeat, you have a lowered blood pressure, you have an abnormal level of consciousness, you have abnormal oxygen, maybe an abnormal temperature. So these things all come up in the news score. And I have seen a number of seriously unwell, severe influenza cases that could have been there could have been meningitis, there could have been influenza, there could have been severe pneumonia. And really, I don't have the ability to tell the difference between those three things. And even if I was investigating in my clinic, which I usually don't, it's not actually going to answer the question, because you need to rule out, all three of those situations. And so those patients are identified, and then they're sent to hospital, hopefully via an ambulance. And with this flu situation in the last few months, we had a couple of very sick people, one who collapsed in the clinic, and it did turn out that both of these patients, so one was 16 and was a differential of meningitis and had a CT and a lumbar puncture, and the other one was sepsis versus influenza. Now, both of them had influenza A on their swabs, and like a lot of urgent care clinics, we're not allowed to do these swabs anymore, that only the hospital. And I gather they can be done very rapidly if the intent is there, so within 2 hours. So identifying the unwell patient is what this case, I think, highlights, that when someone has abnormal parameters, abnormal physiological parameters, something should be done to correct that, and that should include probably a referral acutely to hospital. And I think that's the takeaway point. This person was severely unwell. It turned out to be pneumonia, but it might not have been pneumonia.
And the news score, you've got it there from mdcalc.com, enables you to fill it in on the page here, and then it gives you a thing at the bottom. It scores it for you. And in this case, I've just theoretically put in some numbers here, and it came out with 9 points. High score, emergency assessment, critical care outreach team recommended. So it walks you through the doing of the score there, and it gives you quite powerful information to decide whether to refer into hospital or not.
It's a really good adjunct. You can do it online where you work. You can do it on your smartphone. You can have it printed out and draw numbers on things. And when you have clearly abnormal parameters, it can get you past that mindset of saying, oh gosh, this person's got man flu, to, oh, this person's actually quite unwell. And if you have influenza, you can be very unwell. I mean, you've got to remember that 20 million people died in 1918 from influenza. So just because it's something you can't treat with antibiotics doesn't mean that they're not severely unwell. So it's a good score, and it can help you go through the mental process of, what do I do with this patient now?
And it involves the AVPU score as well, which is a nice, simple scoring thing, rather than doing a GCS and having to remember all of those other...
We had great struggles with the AVPU score, but the reality is, if you're using the Australasian triage score, which everyone is supposed to use, then you need some level of alertness. And it doesn't really matter which score you use, but most important is, are they alert or are they not alert? And that should be an alert in itself. And it's pretty easy to just write one word, alert, in the triage every time. And I tend to write it in my notes as the very first word when I'm reviewing someone, and that they seem maybe a little bit unwell is are they alert? And then I move on from there as to what their cardiovascular parameters or respiratory parameters. And you're foolish if you ignore abnormal parameters. If you actually think, gosh, this person is so well, they can't be that unwell, then you should probably write in your notes, document why you think that's the case, that because they've been crying, their heart rate's artificially elevated in a child, and it returned to normal. And that's a great protection for yourself if something were to go wrong.
Yes, I certainly think the news score is a nice, and MD Calc is a good way of scoring Wells scores and other EDAX type scores. So it's a good thing to have, like you say, on your phone or your desktop. And the other story was just relating to something which I was told about in my last ACLS course, which was the Good Sam app, which people can download. And I know we talked about this off air, so to speak, a few weeks ago. This is an app which you can download to your phone and register with, and if you are within the vicinity of a cardiac arrest, the St. John's will send you a ping and you can volunteer to go and help. And the studies around the world have shown that it gets first responders with the requisite skills to people faster than the ambulance service can, and it enables you to film what's going on for feedback, and people can be instructed over the phone. And there was an article in Stuff again where this had been used to help save a man's life. And I think when we talked about it, you wondered whether, do you want to be on call all the time is one concern that some clinicians might have, or whether you feel that you might be in the right place, or if you're out shopping, or if you had a few drinks in a pub, when does it become a burden? But it's certainly a great idea and concept to get people to, it could be happening around the corner and you don't know about it. This at least lets you become aware of it.
Yeah, and I guess it's all about the sense of community of where you live or work, and it is a particularly fantastic idea, and certainly I know my last ACLS, they talked about it as well, and it is an incredibly useful tool for the cardiac arrest situation, but I think it's up to each individual to decide whether they want to be involved in this. It does pose some challenges for when you're actually at work at a clinic, because you can only go so far from your clinic safely. You're not necessarily as mobile as a paramedic, and when you're out of eyesight, the clinic may lose all its resuscitation equipment. So it's not going to be as good in that situation unless you have the ability to actually send someone away. So it's probably more outside work than actually inside work, although in some circumstances that may be useful when someone's really nearby.
If you go to your app store and have a look at the Good Sam app, you can obviously make your own mind up if you want to enroll in that, but it could mean, in this case, it seems to have had a beneficial outcome on this gentleman's life. So it certainly has, and it is used around the world, and there's good evidence that it reduces the time to good quality CPR. And what we talked about in the last episode was that's the important thing: good CPR and early electricity. So that was a nice story to see. And if we go on to college news, we've got the exams next month, which you alluded to last time, Dave. We've had one question from somebody just wanting that the people that they work with are a little bit longer in the tooth and haven't done the exams as recently as some, and so they were wondering what to expect on the day of the exams. And I wondered if you'd maybe would be able to say a few words about what somebody can expect.
So an update on the UCPICS exam for 2018. There is some information on the college website. The written paper is on Friday the 16th of November at the Manukau Institute of Technology. The written paper is going to be finalised very soon. It'll be about 80 short answer questions and 20 multi-choice questions. These are based almost entirely upon the urgent care course online, and then other bits of information that are gathered from the textbooks and the courses, but its majority is the urgent care course online. The OSCE is on Saturday the 17th of November at Manukau Super Clinic. There is at this stage going to be 2 OSCE groups, with the preference to those who are from out of town, or preference to be given to the first OSCE group. The second OSCE group could be chosen if someone was wanting to stay in town anyway, but preference to those from out of town. And the OSCE will be just under 3 hours long for each group, 7 minutes for each station and 2 minutes in between. It looks like that will probably be about 19 stations, with 18 active stations and 1 rest station. And this is based on clinical skills, so it could be anything from an examination, a history taken, or a radiology interpretation. And more information can be got from the college if you need it. I think that's the main thing about it. Obviously, the skills demonstration weekend this year highlighted how clinical skills should be done. And if you haven't been doing OSCEs for some time, it's a good idea to grab your supervisor and say, let's go through this examination for 7 minutes, and perhaps practice interpreting radiology as well in the correct format.
Certainly, I found it a very fair exam when I did it. It seems to reflect what we do in practice. It's not designed to catch you out with some weird serum rhubarb kind of medical idiosyncrasy. It's very much based on what you see and what you do on a daily basis. I hope it's still very much like that.
Well, I hope so too.
That's good. But yeah, it isn't like you hear stories from like people doing their membership exams for colleges of physicians and whatever, where there's really kind of crazy, inappropriate stuff that's not really clinically relevant. This is a fair test of being a good urgent care doctor. That's my experience anyway.
Well, I certainly hope so. And there's a team that have been putting it together this year, as every year, and I think they've done a very good job.
Great, so that's coming up next month. And any other college news? I don't think there is there? I think that probably draws us to a close. So thank you, Dave, for joining us again and giving us your wisdom, particularly around head injuries and concussions. If anybody has any comments or anything they want to contribute to the podcast, there's the email address podcast@rnzcuc.org.nz. You can also comment on Facebook, because the the podcasts go up on Facebook, and you can comment underneath them. We encourage people to let us know what you think, if you've got ideas, or if you want any topics covered, or if you want to disagree with anything that's been said, let us know, and happy to hear and feedback that at a later date. And if anyone wants to contribute a piece, if they want to be doing something that particularly interests them, then please let us know. And you can be anywhere in the country. We can record remotely, so there's no excuse if you're based down south and you think this is all Auckland based. We can literally do this from all over the world. So thank you, Dave, again, and no doubt we'll hear from you next time. But for now, thanks for listening. The information discussed in this podcast was intended for the ongoing professional development of qualified health professionals and should not be used for self-diagnosis. For any personal medical concerns, please consult your usual doctor.